Hi, everyone, and welcome. I am Jeremy. I'm a representative of EHN Canada. We are a nationwide network of treatment centers for addiction, trauma, and mental health. We have facilities located in British Columbia, Alberta, Ontario, Quebec, and Nova Scotia. We offer high-quality inpatient, outpatient, and online treatment programs. For more information, please visit our website at www.ehncanada.com. Just in terms of housekeeping, everyone is on mute and cameras are off for today's webinar, but please feel free to use the Q&A box located at the bottom of your screen to submit any questions for our speaker. We will try to get to as many questions as we can at the end of today's session. If you are wanting to turn off the chat preview, please check the up arrow located on the right of the chat box and uncheck the chat preview option. And please remember that this is a professional and inclusive space, and any offensive commentary will not be accepted nor tolerated. Today's webinar is being recorded, and we will be sending out a follow-up email sometime mid to late next week that will include a copy of the recording to today's video, any useful resources, as well as the slideshow presented, and of course, your CEU certificate. Again, we will send an email sometime mid to late next week with a copy of today's webinar recording, the slides being presented, additional resources, as well as your CEU certificate. Today, I am actually located at our Edgewood Treatment Center in Nanaimo, British Columbia, and it is on the traditional and unceded territory of the Coast Salish people, the traditional territory of the Sunimuk First Nation. And Vancouver is on the unceded territory of the Musqueam, the Squamish, the Tsleil-Waututh nations. Teresa is located in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. If you are new to this work and want to find out whose land you are on or grew up on, check out www.native-land.ca. Many more of you may be physically present elsewhere, and I encourage everyone to use the chat function to, where applicable, share whose land you are on. Now, to get to today's session, Youth Mental Health and Addiction Treatment Practices, we have Teresa Bansen joining us today. Teresa brings extensive experience working alongside youth and their families, including having worked in clinical team lead roles for eating disorder programs at the Hospital for Sick Children and BC Children's Hospital. Teresa is passionate about working with teens, individuals, and families experiencing a variety of social and mental health struggles within strength-based and trauma-informed frameworks. Please help me welcome Teresa. Thanks so much for joining today.
Hi, everyone. Thank you, Jeremy, for the introduction. I'm hoping you can all hear me and see me okay. So yeah, thanks for having me today for the webinar. I'm going to be talking, as Jeremy mentioned, about youth mental health and addiction treatment practices. And so just to go over some of the learning objectives. So there we go. The first is just to sort of provide an overview of youth mental health and substance use and kind of what the current landscape looks like. Then I'll talk a little bit about diversity, equity, and inclusion within programming, and then talk a bit about the components and strategies to achieve holistic healing for youth. Okay, so just to kind of get us started off, I want to provide just a little bit of an overview of some of the topics that we'll cover in more detail as we go along. You'll see sort of on the left-hand side, the first category there is mental health and substance use. We know that, of course, these are issues that teens have been struggling with for many decades. That's probably not news to anyone. But I also do want to highlight that the other three categories on this slide are relatively newer concerns that teens are facing. And certainly we're seeing parents and families raise these concerns regarding social media, technology, gaming, and the impacts of COVID more and more frequently. So the first category, in January 2020, we know that about 28,000 Canadian children and youth were actually on wait lists for mental health and treatment. And that number has actually more than doubled since 2017. And given the impacts of COVID and sort of the crisis that we're experiencing around mental health, we can imagine that this continues to worsen for youth, and we even know that some wait lists are over a year long at this point. The second point there, so in Canada, 27 to 50% of youth who die from suicide actually meet the criteria for having a substance use disorder. And so this is a really important point that I want to highlight, because we know that mental health and substance use have a huge overlap, and they commonly occur at the same time. So I'll also speak to this a little bit later on in the presentation. To the right of that, social media and technology. So 1 in 6 secondary school students report symptoms that suggest a moderate to serious problem with technology use. In regards to gaming, 1 in 5 students meet the criteria for a gaming problem, and that's as per the PVP scale. And then in terms of impacts of COVID, so again, we know that COVID really has exacerbated the mental health crisis, especially for youth. And I think while we're starting to get a little bit more information and understand kind of the impacts of COVID, there's still a lot that we don't know. And I'm sure there are impacts that we may not fully see, until years down the line. Hopefully not, but maybe. Having said that, what we do know is that youth are reporting the greatest declines in mental health since the pandemic, and statistics are showing as much as a 20% decrease in mental health. We know that there's, again, a strong correlation between mental health and substance use, and so specific statistics have shown that since the pandemic, those with poor mental health are up to 4 times more likely to report increased substance use. And so that is a statistic for the general Canadian population, but we can also, I think, assume that youth are also being negatively impacted. And then the last point there, I just want to also acknowledge that equity-deserving and equity-seeking groups are, of course, disproportionately affected by the pandemic. And we will get into that into more detail later on. Okay, so for the next few slides, I'm going to highlight a study called the Ontario Student Drug Use and Health Survey, and some of the key findings that came out of this last report, which was in 2021. So just to give you a bit of context, this study is Ontario-based. It's a survey of students grades 7 through 12, and it's conducted every 2 years, and this has been going on since 1977. So pretty helpful in terms of, getting a sense of trends and things. And so this study tracks trends on mental health, drug use, bullying, physical health, gambling, and other risk behaviors. This 2021 report actually included new questions around disordered eating, cannabis advertising, as well as COVID impacts. And the surveys are self-reported and anonymous. And for the 2021 survey, it was sent out and completed online because of COVID. Before I get into more of the specific statistics, though, just a few things to note. So the surveys are done within Ontario's publicly funded school system. So that does mean that there are some groups that are excluded. So those would include private schools, those who are homeschooled, who are maybe in a correctional facility or away for health reasons, those in First Nations communities or remote northern regions of Ontario are not included in these statistics. So just something to keep in mind. Okay, so just to talk a little bit more in depth about some of the findings from the study regarding mental health from grades 7 to 12. So over 1/3 of students reported their mental health as fair or poor. Approximately 1 in 6 students report feeling lonely often or always. Close to half of students report feeling moderate to serious levels of anxiety or depression within the last month. Within the last year, 1 in 5 report purposely harming themselves, and 1 in 6 report having serious suicidal ideation. While there was a desire to talk to someone about their distress reported, just under half of the students said that they did not know where to seek support. Okay, and substance use. So some more statistics here. 1 in 3 students reported consuming alcohol within the last year, a quarter within the last month, and more than half have tried alcohol in their lifetime. So I think that's about 60%. I mean, these statistics probably aren't a huge shock to anyone. As I mentioned before, mental health and substance use has, been an existing issue for youth for some time. But again, I'll cover some of the other kind of, concerning and maybe newer statistics. Okay, so 1 in 6 report using cannabis in the last year, and about the same number report using electronic cigarettes or vapes. 1 in 8 report the non-medical use of prescription opioid pain relievers. So that number for sure is quite concerning, especially when we take into consideration that some youth may be underreporting, and then there are many communities that were not even captured in the survey. 1 in 7 secondary school students, so that would be grades 9 to 12, not 7 to 12. So 1 in 7 report symptoms of a substance use problem, and that's as measured by the CRAFT screener. Okay. Next we have social media and technology use. So almost 1/3 of students spend 5 or more hours on social media each day. 1 in 7 report spending 7 or more hours on social media per day. And close to 1/3 of students reported being cyberbullied at least once within the last year. More than half of secondary students, so again, this is just for grades 9 to 12, report spending at least 5 hours a day or more on electronic devices unrelated to school or work. Approximately 1 in 6 secondary school students report symptoms that suggest a moderate to serious problem with technology use. And again, just to highlight, these are concerns that we definitely see being raised more frequently by parents about their teens while they're in treatment. Okay, online gaming. So just under half of students reported playing video games daily. Close to 1/4 of those play for 5 hours or more a day. 1 in 5 students meets the criteria for a gaming problem as per the PVP scale. Roughly 30% of students who played video games in the last year reported spending more time playing when they felt bad or felt like they had a problem within their lives. And again, obviously that raises some concerns just around coping and skills for regulating emotions. About 12% reported hiding video game playing from either family or friends within the last year. And about 8.5% reported skipping school or work or lying or arguing in order to play video games. Okay. So that was just sort of a bit of a summary, as I said, from that study. It's helpful just to give us a little bit of information. But of course, as I mentioned, there are some gaps with regards to data collection, excluded communities from the survey. And so I want to take this moment and sort of the next few slides really just to highlight the importance of diversity, equity, and inclusion within programming, and, you know, of course, within data collection and in that. So yeah, we know that having a health equity lens is really important to the work that we do with youth and families. And so I'm going to highlight the information that is available despite the lack of data that we do have on equity deserving groups. Okay, so yeah, as I mentioned, unfortunately, there is currently a minimal amount of research on general racial disparities within Ontario and Canada, and much less of that is catered towards the mental health system specifically, and then even less of that is catered to youth. And much of what is available, the data actually lacks direct input from these communities. And so that's significant and quite concerning. So information on the topic of race and mental health is crucial because children and youth from marginalized communities are the most at risk of developing serious mental health conditions, and yet they are the least represented in care and treatment. The little research that we do have tells us that BIPOC youth are disproportionately affected by the social determinants of health, and are often subjected to culturally insensitive and culturally incompetent environments when engaging with the mental health system. There are evident parallels between the effects of social exclusion on mental health and access to related services. And equity-seeking groups such as Black, Indigenous, 2SL, LGBTQIA+, Francophone, and immigrant communities are less than half as likely to come in contact with mental health services compared to the general population. And in a study as recent as 2021, it was shown, perhaps unsurprisingly, but unfortunately, that social class and race are, of course, linked to health inequities. Okay, so I'll speak a little bit to African community, Caribbean and Black communities. So a Canadian longitudinal study found that Black immigrants were more likely to develop mental distress in comparison to other ethnicities. People of Caribbean and East and West African origin in Ontario have a 60% increased risk of psychosis. Black Ontarians of Caribbean descent have 2 times the delay in getting evidence-based services than those of white European descent. Black Ontarians experience a higher level of adverse pathways to care. So that means things like accessing the emergency room or ambulance when compared to their white counterparts. And Black Ontarians experience higher rates of restraint and confinement under the care of the mental health and addiction system. So for the 2SL LGBTQIA+ youth in Canada, so in 2018, from Stats Canada, youth aged 15 to 24 made up about 1/3 of the population. Of the LSGBTQIA plus population. There was a study that came out of the Canadian Trans Youth Health Survey Research Group, and it found that 70% of Canadian youth who identified as transgender reported experiencing discrimination based on their identity. and then sort of more general statistics in the adult population within this community. So we know that Canadian individuals within this community are more likely than heterosexual Canadians to report that they consider their mental health to be poor or fair. They are also more likely to have seriously contemplated suicide in their lifetimes, and to have been diagnosed with a mood or anxiety disorder. And in terms of some statistics as it relates to COVID, in another study, gender diverse participants were almost 3 times more likely than cisgendered male participants to report that they had experienced discrimination during the pandemic. And as I mentioned earlier, COVID has exacerbated mental health generally for the population, for youth, and especially for youth part of this community. And then in regards to access to services, this community is 3 times more likely to face inequitable treatment in comparison to the general population. Okay. So, I mean, of course, there are many other equity deserving groups that I would love to highlight. Unfortunately, I won't be able to do full justice here, but I do want to recognize and acknowledge the following. So just a few more statistics. South Asian males are more likely to develop mental distress in comparison to other ethnicities. Visible minority groups in Canada are more likely to report that the pandemic has had a moderate or major impact on their ability to meet their financial obligations when compared to their white counterparts. And the highest rates of this seen among South Asian, Black, and Filipino populations. And as you might expect, the prevalence of disabilities among Canadians tends to increase with age. However, in 2017, it was estimated that more than 540,000 youths aged 15 to 24 had 1 or more disabilities. And so that, in other words, is more than 1 out of 10 youth have 1 or more disabilities. And to speak a bit about anti-Asian racism statistics. So between 2019 and 2020 in Canada, the police reported anti-Asian hate crimes increased by 301%. And so that is obviously quite concerning. In Vancouver as well. So during that same time frame, so from 2019 and then 2020 hitting in and around the time of COVID, the incidence of anti-Asian hate increased in Vancouver specifically by over 700%. So yes, very, very problematic and upsetting. Okay, so you probably have noticed, or maybe you've noticed, that I haven't talked about First Nations, Inuit, Métis, and urban Indigenous communities yet. And the reason for that is that I want to adhere to and respect OCAP principles. So OCAP, it stands for Ownership, Control, Access, and Possession. And it asserts that First Nations have control over their data collection processes, that they own and control how information can be stored, interpreted, used, and shared. And so alongside the Assembly of First Nations, OCAP was developed due to the harms that have been caused when data is not analyzed, interpreted, presented by their community. Yeah, so in keeping with that and in honoring data sovereignty, I'd like to read from parts of a quote by Leona Starr, who is a chairperson with the First Nations Information Governance Center. So it reads, Data sovereignty is among the most pressing issues facing First Nations. We recognize that information, knowledge, and research are critical to accessing resources, influencing government policy, and assessing the effectiveness of policies, services, and programs. Access to timely, relevant, and quality data is essential to advocate for the change needed to address health disparities nations have experienced as a result of colonization and systemic racism. Okay, so all of this sort of leads us to, I guess, a conversation around like, what do we do about all of this? Obviously, it's hard to hear those statistics. And I mean, you know, sort of from my social location, it's that, you know, obviously impacts me differently because I'm not, you know, I have a lot of unearned privilege around these topics. So, yeah. So what I do want to highlight is some recommendations and things we can do moving forward to help start to create safer places for marginalized communities and equity deserving groups. So I've outlined a few key recommendations, and just to give you a bit of context. So in 2021, a report was released from the New Mentality, which is a program of Children's Mental Health Ontario. And so it engages and amplifies youth's voices in the child and youth mental health system. So they created a youth action committee. And so youth members across Ontario work together, and they develop youth-led policy recommendations with the goal, of course, to create change within the mental health system. So I've highlighted 3 of these main recommendations. Bellwood is currently actioning these. And some of these recommendations are informed by the report. I would also strongly encourage you to check out this report, take a look. I have listed it in my references, but I will name it right now just so you can hear it as well. So it's called Adjusting the Spotlight, Recentering Neglected BIPOC Youth Voices Surrounding Mental Health. And it can be found on Children's Mental Health Ontario's website. But again, it'll be in the references, and you all will get a copy of the PowerPoint after today's session. Okay, so number 1. So the first recommendation is to offer continuous anti-racist and anti-oppressive training to help create culturally sensitive environments. And so in other words, training shouldn't be seen as just like a one and done checklist sort of thing. Like it needs to be ongoing, and there needs to be follow-up with it as well. Number 2, so an ongoing commitment to hiring from diverse communities. And so one of the things that is also, I think, very important is like actively reaching out to and recruiting from diverse communities about potential career opportunities. And of course, it's because, you know, the populations we serve need to be reflected within the organizations and within staffing. And we know that, you know, diversity, equity, and inclusion, it's not just beneficial for the clients that we serve, but it's also best practices for organizations, right? Because it considers bunch of like multiple and important perspectives. Yeah. And so number 3, ensure continuous and consistent engagement with community members and equity-seeking groups. Not only do we need representation within the organization and within staffing, but we do need to incorporate continuous engagement with diverse communities. And it's important to note that we don't treat identities and communities as a monolith. We want to seek out varied representation, varied perspectives, even within one community. And so what that can look like is setting up steering and advisory committees, and doing that in a way as best as possible that is not exploitative or appropriative. And so that also means ensuring that people's time and expertise is honored and reimbursed accordingly. Okay. All right, so that brings us to Bellwood's Youth Program that we're launching June 12th of this year, which we're very excited about. It's been in the works for a long time, and so it's certainly exciting to have a launch date and have things ready to go. So I'm just going to be highlighting our treatment approaches and different treatment components that we're going to be offering. Okay, so the Bellwood Youth Program, so it's a 12-week intensive outpatient day treatment program, and it is designed to increase access to concurrent treatment for mental health and substance use disorders. So as we talked about earlier, we do really want to ensure that youth and their families are accessing services that can work on mental health concerns, substance use, eating disorders, those types of things at one time. The mental health system can tend to be quite siloed. And so in my experience working with families, programs often will have exclusion criteria for youth surrounding substance use or eating disorders. And so in trying to access one, they'll usually say, oh, well, you need to work on this first. And so it can be quite frustrating for families, and just in my experience. And so currently, we are launching sort of the first phase of two phases. So the first phase, and this is what I'm going to be outlining, is a day hospital setting. So what that means is that youth come in Monday to Friday, sort of during business, school, working hours. So, sort of between 8 to 5 or so. And then they're home evenings and weekends. Our future plans, which we're working on for phase 2, we do hope to open up 6 of those 12 spots to make 6 live-in beds, but there will be more to come on that. Okay, so more specific program information. So we serve youth between the ages of 13 and 18 and their families. Again, we offer intensive outpatient treatment for substance use, behavioral addictions, mood and anxiety disorders, trauma, eating disorders, and concurrent disorders. The length of stay is 12 weeks, again, within sort of the day treatment setting. Treatment components, so individualized treatment plans, individual and group therapy, family therapy and support, nutrition, education and support, and then including somatic and activity-based interventions, as well as relapse prevention. There will also be an academic component to the program, because most youth are attending school when they're coming into treatment. And so there will be some dedicated time for youth to be able to work towards their credits and other goals that they might have, school related. So just to go into a little bit more detail of the supports that we are offering. So we will have child and youth counselors as part of the team. And so they play an active role in the treatment, sort of acting as the kind of in the moment point person for youth. They help co-facilitate groups, participate in treatment reviews and other aspects of the youth's care. Individual therapy will be available for youth who would like to access that. And, that's just to sort of help deepen their learning and understanding, and can also be a helpful tool for youth if they want to, bring up some things that are coming up for them kind of within the larger group or within family therapy if and when appropriate. And then family therapy. So our program is very much family-based, and family, of course, can look like a multitude of things. It's different for everyone, but whether it's family caregivers, family friends that are very present in the youth's life. So we will provide weekly family therapy. And of course, it's just to sort of help improve communication and parenting strategies. Yeah, I think it's also important to acknowledge that a lot of, families sort of, there's issues with their teen, right? And so they're seeking treatment and support for that. And I think a lot of parents at times maybe don't know how impactful it can be to have for them to be present, right, and actively engaged in the treatment process. And so again, that's part of why we are so family focused. Okay, registered dietitian. So there will be nutrition, education, and support available for clients and their families. And for those who do struggle with eating concerns or an eating disorder, the dietitian can also work more specifically with the youth and family around like challenging and overcoming presenting food concerns. On-site consultations from a psychiatrist will also be available sort of as needed if the youth would benefit from assessment or diagnosis. And then there's also, in addition to the weekly family therapy, there will be weekly multi-family and parent caregiver support groups, which we hope will help to build connection and community, for the parents. Yeah, and again, just to sort of help parents feel better equipped and build their own capacity and maintaining meaningful connections with their youth. To go into a bit of detail of some of the modalities that we're going to be using. So DBT is one of the modalities. And I'm sure as you're all aware, it's, helps to effectively regulate emotions and things. And it's a bit more skills based. And then we are also really wanting to focus on and include more sort of like somatic body-based therapies within our program. Of course, DBT skills are very helpful. And with some youth, it can be hard to sort of like sit there and focus and think about homework and, DBT homework and that kind of thing. So we are really trying to sort of shift into more body-based therapies. So with that, internal family systems is also going to be a focus of the treatment program to help build the mind-to-body connection, reduce shame and guilt, and heal underlying trauma that may be driving the distressing behavior. Activity and somatic-based therapies, so that's also to help aid in processing of trauma that's stored within the body. Relapse prevention skills and art therapy, as well as emotionally focused family therapy will kind of be the main modality for the family therapy. Okay, I think that is, okay, so here are the references. And then that's it. So I think we will have some time now to take some questions.
Absolutely. Thank you so much, Teresa. We have lots of questions. So if we'd like to get to some, let's get the ball rolling. So there's just a general question too. So curious if the stats differ for youth involved in activities, sports, arts, social clubs, whatever it may be, versus those youth that are not involved in terms of mental health and substance use?
Yeah, that's a great question. I don't know, sort of the short answer. But what I can say and maybe speak to just in my own sort of experience anecdotally is that I would imagine that would help, right? Like with youth feeling, kind of more engaged in their lives and engaged in different communities, whether it's around sports and things. Yeah, typically that helps improve mental health. But yeah, I don't have any specific data or sources to cite around that.
Yeah, totally fair. We can also look into it for a follow-up resource as well for the email to be sent next week, so that's no issue. So speaking to the Bellwood Youth Program, what is the plan for those youth that are not committed to the program? So for example, if they still continue to use outside of the program.
Yeah, so I mean, I'm sure for many clinicians and certainly with experience working with youth, it's tricky, right? Like every person is different, and so maybe what I can say is, like, generally speaking, the program is meant to be voluntary, right? So we can't force youth to be there who really do not want to be there. And we also do want to try and work with families and youth as best as we can to support them in getting the most out of the program. I know that's kind of a vague response, but I think it might be, yeah, like working with parents around some coaching, if that might be helpful. Asking the youth sort of what's going on for them and what components might be helpful for them. Like there could be, I think, a lot of different ways to approach that. But certainly a tricky one for sure. Yeah.
For sure. Thank you so much. And then going off of the Bellwood program again, so is youth peer support part of the treatment process?
Yeah, it's a great question. So right now, no, we don't have something explicitly like that. Having said that, we are sort of, I imagine that the youth program it's going to evolve sort of as we have more youth in and as we do some of the work around engaging with community and so I imagine that at some point that could be part of it, or we're just better engagement with community generally would be a goal, but there isn't anything sort of tangible right now.
Perfect. And then we do have a question too, just in general. What would you suggest for a youth is struggling, but is treatment resistant or resistant towards programming?
Yeah, I mean, again, I think it depends on your relationship with the youth and that sort of thing. I think just generally having a conversation about how they're doing. I think a lot of the times it can feel really overwhelming, and a lot of youth feel a lot of shame and guilt around some of their behaviors. I mean, obviously, I'm not sure how involved parents are with this, but understandably, most parents who learn of their child's substance use or other risky behaviors, like, it comes out of a place of fear, right, for their child, but sometimes it can come as sort of like a little blamey, shamey. Not that that's the intention, just because they're so worried about use. So I think just trying to have open, non-judgmental conversations about it. Maybe you've already done that. I'm not sure kind of the context. And I think just kind of like encouraging and letting them know that, like, you're there to talk with them if they need anything, if they want to talk through anything. I don't know if they're open or willing to have some conversations around, what, how the substance use is impacting them. And I think one of the things as well is, like, that conversation can look like, what does this do for you? Like, I think a lot of the times we're scared and worried about talking about substance use or, other issues as negative, bad, horrible coping skills, right? And we don't want to sort of inadvertently reinforce the behavior, but really at the end of the day, like, we're all human, and all of our behavior, like, we do for a reason, right? If it might not have the best, sort of long-term impact, but what is it about using that this youth likes, right? Like, maybe it is a really helpful way that they can numb out. Maybe it's a way that they gain entry into a social circle, right? And those are sort of friends that if they weren't using, they wouldn't be able to access, right? So things like that might be helpful to explore a bit.
For sure. Like you touched upon too, it's very individualistic, right? Like it's very circumstantial with this kind of stuff. And you talked about too, like you might have already tried talking to them. You might have already tried, like there's a bunch of different variables that tie into that kind of stuff too. So it's important to acknowledge that too, and to acknowledge that progress being made by the caregiver or the parent. But there's steps to take with every single patient too, right? So just being aware of options and resources, I think, is a big, big step.
Yeah.
And then going back to the Bellwood program specifically. So for the Bellwood Youth Program, does the mental health diagnosis have to be formal through a psychiatrist, or is it self-reported?
No, so it doesn't have to be formal. It can, yeah.
Okay, perfect.
Just leave it at that. It doesn't.
Yeah, it does not have to be formal. Okay, and then there's some questions too about like wondering what qualifies as social media use. So I know this kind of goes back to the survey, and it might be a little bit more specific information, but like what kind of qualifies as that? Is it like a constant scrolling? Is it constant like engagement? Is like what would kind of constitute social media use in that case?
Yeah, so my understanding, looking at that study, was when they talk about social media, it was like like time spent on social media platforms like Instagram, TikTok, Facebook, those types of things. Don't quote me, or I don't want to misrepresent. Yeah, we can certainly take another look at the survey, but that was my understanding of what that was.
Perfect. And then just going off of that too, like what qualifies as a moderate to severe problem with technology use? So like what symptoms would be present?
Yeah, so that's a great question. So that I would, again, because I don't want to give misinformation, I would recommend, and this is something maybe we can do as well, actually looking at the scale, like the psychometrics that they use to capture that. So I'm not exactly sure sort of what the cutoffs are in terms of like frequency and that sort of thing, but that would be outlined using, I think it was like the PPP scale for that question or that statistic. And so that would also be clarified there. I just don't want to like misquote or provide misinformation.
Absolutely, totally understand that. And then for the program itself, is there any type of aftercare or follow-up procedures set in place?
Yeah, so another great question. We are currently sort of figuring out and confirming what exactly that's going to look like for families. But the idea is that they will have at least some sort of follow-up. But I guess more to come on those specifics.
Perfect. Thank you. And then there is a question too. Sorry, I just lost it. So for the First Nation youth, are they able to access traditional knowledge keepers, elders, and is this programming culturally based?
Yeah, so another excellent question. Part of opening up phase 2 was to have the opportunity for youth who are not necessarily Toronto based. I mean, I know, of course, there are urban Indigenous youth living in Toronto, but just to make it more accessible to other communities, especially more remote communities. And so we have like a lovely director of community engagement who has been doing a great job of actually connecting directly with some of those communities. And so we are actively looking at some of our practices and helping to ensure that there will be culturally based care available. But yeah, it's that one that's still in the works. But yes, that is a really important flag, and we are wanting to do that very mindfully.
Absolutely, yeah. And even at our Edgewood facility located in Nanaimo, like there is an Indigenous specific consultant that like deals with all the programming to make sure that these audiences and demographics are being addressed in an adequate manner and that they can speak to their experience too, because they are Indigenous themselves. So again, like you said, we have a lovely director working on this tirelessly, and there's progress being made, which is super important. But a big thing with equity, diversity, and inclusion is that there's always work to be done. So it's just being mindful of that too. I think it's super important, and to grow from there too.
Yeah.
And then there's just a question about the program. So are you currently accepting clients for this program, given that the launch date is June 12th? Should they contact you directly? Like, what would the methods be for this?
Yeah, so they can start connecting with our admissions team for referrals. So yeah, our admissions team, they're prepped and ready. And I believe our website is up soon. I can't remember. Yeah, okay.
Yeah, it'll be up soon.
Okay, yeah, so in the next couple of days or so, I think I don't know. I don't want to put timelines on it, but sorry. Short answer, yes. You can contact admissions.
Yeah, admissions is, like you said, very well versed with this now, and they'll be able to connect you with the correct people, go through referral process and everything as well. So highly recommend reaching out to Bellwood Admissions, and they can direct you accordingly. How do you plan to monitor success and sobriety for those youth attending during the day only when they have access to substances outside?
Mm-hmm. Yeah, so that again is a tricky thing to navigate. I do think it will be individualized as well, right? Kind of depending on the youth's treatment goals, whether it's, sort of more harm reduction, or if the youth themselves are wanting, complete abstinence. In part, that's also why we're opening up some of the live-in beds as well, right? Because it is quite challenging to sort of be out, in the world, the evenings and weekends. In some ways, that can be really helpful in terms of practicing the skills, kind of like live in the moment, and having the opportunity to come back with the group and talk about it and process it, and with therapy. But yeah, I think it'll depend on the use. Goals.
Yeah, like you said, and we've talked about too, it's an individualistic thing, right? Like some people would benefit from the kind of hybrid approach with being in person for treatment during the day. And then, like you said, are able to kind of put that into action in the evenings, and to test themselves to see if it's applicable for them. But then other people need to be completely isolated and removed from that situation for an extended period, right? So that's why we have like inpatient, outpatient, virtual, like there's a bunch of different offerings for treatment just as a whole, because treatment differs on the person.
Yeah. And the only other thing I'll add to that right now is like using families, right? And sort of, family and or the youth community to support as well. Can be really powerful and helpful when parents are on board and are able to help. I don't want to use the word like contain the youth, but you know what I mean, to sort of support the youth through the recovery, maybe in a way that some adults don't have that option.
For sure. Yeah. And it looks like we have time for one more question. So I know you touched upon the logistics for the 12-week program, but How many youth are able to access the 12-week program, and is it just during Monday to Friday?
Yeah, so the 12-week program, there are 12 spots in total for youth, and it will be rolling admissions. So it's not cohorted. So it's not like, 12 people start for 12 weeks. And then if you get referred, you have to wait a full 12 weeks. It will kind of be ongoing admissions. I think that answers the question.
Yes.
Yeah. Okay.
Yeah.
Sorry.
No, that's all good. And yeah, with that, unfortunately, it looks like we're coming to time because we are coming to the end of our session here. So Teresa, thank you so much for providing your insight and expertise with this, and super excited about the Bellwood Youth Program upcoming.
Yeah, thank you all for having me. And yeah, thank you.
And for everyone else that attended today, thank you so much. And as mentioned at the beginning of this webinar, we will be sending out a copy of the recording of today's presentation, as well as the lovely slideshow that Teresa shared with us. And we'll look into some additional resources that were brought up throughout the session to share within that email. And of course, your CEU certificate. We will be sending that sometime mid to late next week. So we appreciate your patience in this time. Thank you so much. And until then, take care.